Hello everyone, today I will be presenting on the association between Lynch syndrome and endometrial cancer, an important topic in gynecologic oncology. Lynch syndrome is an autosomal dominant hereditary cancer syndrome and is the most common inherited cause of endometrial cancer. Notably, endometrial cancer may be the first presenting malignancy in affected women, often occurring at younger age. Recognizing this association is crucial as it guides appropriate tumor testing, genetic evaluation, risk reducing strategies, and family screening. And this presentation, I will briefly discuss its genetic basis, clinical features, diagnostic approach, and management. I will briefly explain what Lynch syndrome is. Lynch syndrome is an autosomal dominant hereditary cancer syndrome caused by mutations in DNA mismatch repair genes, mainly MLH1, MSH2, MSH6, and PMS2. These genes are responsible for correcting errors that occurring during DNA replication. When these repair mechanisms fail, it leads to microsatellite instability and accumulation of genetic mutations which increase the risk of various cancers. In women, the most important associated malignancies are colorectal and endometrial cancer. Importantly, the risk of endometrial cancer may be equal to or even higher than that of colorectal cancer in affected females. Therefore, understanding its genetic basis helps in early diagnosis, targeted surveillance, and preventive management. Women with Lynch syndrome have a lifetime risk of endometrial cancer ranging from 40 to 60%, depending on the specific gene mutations, with MSH6 mutation often showing particularly high endometrial risk. Unlike sporadic cases, these tumors typically develop 10 to 15 years earlier and are commonly associated with mismatch repair deficiency and microsatellite instability. Histologically, most are endometrioid type, but high-grade and non-endometrioid variants can also occur. Importantly, endometrial cancer may precede colorectal cancer in these patients, making the gynecologist the first clinician to suspect the diagnosis. Therefore, universal tumor testing with immunohistochemistry for mismatch repair proteins in endometrial cancer is increasingly recommended to identify patients who require genetic counseling and cascade screening. When to suspect Lynch syndrome in women with endometrial cancer? We should consider it in any patient diagnosed before 50 years of age or with a personal or family history of Lynch-associated cancer such as colorectal, ovarian, or gastric cancer. Multiple cancer in the family, early onset tumors, unknown mutation in relative also raise suspicion. Recognizing these features is crucial as it guides appropriate tumor testing, genetic evaluation, and preventive management for both the patient and their family. Now let's discuss the Amsterdam criteria, which helps identify families at risk for Lynch syndrome. According to these criteria, a family is considered at risk if there are at least 3 relatives with Lynch-associated cancer, spanning 2 successive generations, with one cancer diagnosed before 50 years of age and one being first-degree relative of the other two. These criteria are strict but help guide genetic evaluation and targeted testing, especially in resource-limited settings. However, it's important to note that not all families meeting Lynch syndrome will fulfill these criteria, so tumor testing remains crucial. Diagnosis of Lynch syndrome in endometrial cancer. The first step is tumor testing, including immunohistochemistry for mismatch repair protein and microsatellite instability analysis. Loss of MMR protein expression or high microsatellite instability suggests Lynch syndrome. This is followed by germline genetic testing to confirm mutations in MLH1, MSH2, MSH6, or PMS2. Early identification allows not only personalized patient management but also family screening and preventive strategies for at-risk relatives. Management and preventive measures in women at risk advise transvaginal scan for endometrial thickness annual basis after 30 to 35 years of age or perform endometrial sampling at annual basis after 30 to 35 years of age along with careful evaluation of any abnormal uterine bleeding. However, surveillance has limitation and does not completely prevent cancer. For those who have completed childbearing, risk-reducing hysterectomy with bilateral salpingo-oophorectomy remains the most definitive preventive strategies. In addition, regular colorectal screening with colonoscopy on annual basis after 20 to 25 years of age and genetic counseling for family member are essential components of comprehensive care. Now we summarize the key takeaway about Lynch syndrome and endometrial cancer. Focus on the red flags, early onset endometrial cancer, family history of colorectal or related cancer, and mismatch repair deficiency in the tumor. Early identification allows timely surveillance, risk reducing surgery, and genetic counseling for both the patient and the family. These steps are crucial to reduce cancer-related morbidity and improve long-term outcome. Now let's move to clinical scenario. Focus on the key clues, analyze the red flags, and share your answer in the comment section. Question: a 45-year-old woman diagnosed with endometrial carcinoma reports her father was diagnosed with colorectal cancer at age 48. She has no other significant medical history. What is the most likely underlying mechanism responsible for her condition? Options: Option A, BRCA1 gene mutation, B, PTEN mutation, C, mismatch repair gene mutation, D, P53 mutation. Thank you for your time, your attention, and your curiosity. Remember, every patient tells a story, every family history matters, and your clinical vigilance can make a real difference. Stay inspired, stay observant, and continue to turn knowledge into action.